For all of us at the SRF, it is an honor to be able to provide this forum to the scleroderma community. Today's session will feature 40 minutes on surgical techniques that will help to relieve pain and restore hand function for scleroderma patients. We'll then wrap up with about 15 minutes of Q&A time. The phone lines have all been muted, so if you have any questions, please use the chat box in the conference window. A couple of items I'd like to note before we get started. Some of the images associated with today's topic depict hand surgery in progress and may be a bit graphic. And as always, please remember that our webinars are for educational purposes only, and no information provided is to be considered personal medical advice. It's now my pleasure to introduce our special guest. Dr. James Chang is currently the Johnson & Johnson Distinguished Professor and Chief of the Division of Plastic and Reconstructive Surgery at Stanford University. He received his medical degree from Yale Medical School, graduating with Alpha, Omega Alpha, and cum laude honors. He completed a residency in plastic and reconstructive surgery at Stanford University Medical Center and a hand and microsurgery fellowship at UCLA. He has spent the majority of his career at Stanford, where he is currently professor of plastic and orthopedic surgery. He is also an attending surgeon at Lucile Salter Packard Children's Hospital and the VA Palo Alto Healthcare System, where he serves as director of the Plastic and Hand Surgery Laboratory. Dr. Chang's main surgical interests are in reconstructive surgery of the hand and extremities, which makes him uniquely qualified to lead today's topic. It's now my pleasure to turn the presentation over to James and update on hand surgery for systemic sclerosis. Thank you, James, for being with us today.
Oh, it's my pleasure. Thanks, everyone, for sitting in on this webinar. As we talked about, I'll talk about hand surgery for systemic sclerosis. It's a unique field because in many areas of the country, there are great rheumatologists, but they don't have hand surgeons that work with them so intimately. And at Stanford, we have a big scleroderma practice, but also I have a specific interest in scleroderma, so we've made this collaboration. Scleroderma in the hand goes back many years. If you can see in this slide, goes back even described in the 1700s. But in 1961, at least in my lifetime, the challenges of scleroderma in the hand were quite extensive. And you can see in the excerpt from the article, it says, since involvement of the distal part of the extremities occurs late in the course of diffuse scleroderma, it is hardly significant to the plastic surgeon because the diagnosis is already obvious and the prognosis is so poor. My message to all of you on the line today is that there are things we can do for scleroderma in the hand. If you look at these pictures, you'll see the classic clinical presentation for scleroderma, including on the upper left, you can see some ulcerations at the PIP joint level and some contractures of the fingers. And then on the bottom left, you can see some ulcers at the tip of the fingers. In the middle, on the bottom, you can see, let's see if I can use this highlighter right here. You can see some calcinosis, as that's also shown in the X-ray over on here. We wrote an article several years ago, which I'll ask the foundation to make available to all of you, is on management of the hand and systemic sclerosis. So there are four main areas. One is calcinosis in the fingers, buildup of calcium deposits. Second is contracture of what we call the knuckles, the MCP joints that get extended. Next, the PIP joints get flexed. And then what I'll talk mostly about today is ischemia and digital ulcerations. So I'll go through each of these one by one. First, calcinosis, as shown here in this X-ray. You can see the calcium deposits in the fingers. And if patients have this, they can be very painful. They can get infected. So those are really the indications for surgery. If there are some calcium deposits, but they're not causing any pain or harm, then we tend to leave them alone. However, if they are beginning to cause pain and infections, then in surgery, what we do is we try to minimize the incisions, make small incisions, and then I tell my patients at Stanford, the calcium, they're not hard chunks, but it's like dry toothpaste in a shag carpet. We have to scrape out all the material, irrigate it out with lots of liquid to try to dissolve this material and have it be squeezed out. The reasons why we don't do surgery all the time is because of wound healing issues. As I'll talk about with decreased blood flow to the fingers, if we make incisions in the hand, you have to be very careful because those can not heal and lead to ulcerations. Second issue is the MCP joint contracture, and you can see here, I'll try to highlight right here the the area of the contractures, the fingers become extended because these joints get contracted and they stick up in the air like this. And this is very hard for surgery because the skin is tight, the extensor tendon is tight, and the joints are tight. So when we try to release these, many times they'll spring back into this tight position. So we generally don't recommend surgery unless there are wound issues. The third problem are PIP joint contractures, and this we can do something for. You can see here, these are the PIP joints, and they, instead of being extended, they get flexed down. And so it's very difficult to straighten up your fingers. We're not able to recreate the normal joint motion, but what we tend to offer is fusion of the joints, where we take that PIP joint, put it into a better position, and then we fuse the joint so that they don't move, but that they're in a straighter position. So we actually lock the bones in together. And the last part that I'll talk about for the majority of the lecture are what happens when the fingers turn white because of lack of blood flow. And because of the lack of blood flow, simple little cuts on the fingertips become ulcers like this. So that's the focus of today's talk. But just to recap, of the 4 areas of problems in systemic sclerosis, for calcinosis, we debride only if it's painful. For MCP joint extension contraction, we really don't have a great solution for this surgically, so we don't do treatment. For PIP joint contractures, we would fuse in a straighter position, a more functional position. And then the majority of the remaining talk will talk about the role of sympathectomy and possible bypass. And as Amy said earlier, there are some fairly graphic pictures, but I think they'll be very informative for you because I'll take you right into the operating room and show you how we increase blood flow to the hand. So what happens in ischemia? Ischemia means lack of blood flow. And so as you know, in scleroderma, the tubular structures, the esophagus, and the blood vessels get encased in scar tissue around it. In addition, the vessels tend to thicken, and then over time, if that happens too much, then there's no flow through an artery and the blood vessels clot off. In terms of treatment, we always start non-operatively. Not every patient needs surgery, and that's a main point for discussion today. I will show you lots of surgery pictures, but those are patients who we've really vetted between the rheumatologist and me and decide are good candidates for surgery. So we start with the non-operative treatments that many patients already use. They modify their behavior. They use warm techniques, hand gloves, et cetera, et cetera. I'll talk about some other treatments with medications. And the operative treatment, if we do choose operations, it would be a sympathectomy and a vascular reconstruction. In terms of environmental modifications, and many patients have already found this out. They avoid smoking, they avoid cold environments, and when they are in the cold, they wear gloves and hats and keep the core temperature of the body up, and that'll prevent the blood vessels from constricting and the fingers turning white. In addition, people feel that stress is related to their symptoms of ischemia to their fingertips. So many patients learn some biofeedback techniques and really de-stressing techniques so that these don't add to the vascular compromise. In terms of medical therapy, aspirin has been shown to decrease blood platelet clotting, so many patients are on the baby aspirin. The calcium channel blockers have been shown to be the first line of treatment with nifedipine. And as many people in the audience know, there are many other drugs that are being tested for efficacy for Raynaud's syndrome or the fingers turning white. Calcium channel blockers, through many studies, have shown to be efficacious. Here you can see in multiple randomized controlled trials, there's been significant clinical improvement with calcium channel blockers like nifedipine. So your rheumatologist should be using this as a first-line treatment. Some patients can't tolerate it because of the decreased blood pressure that results from this. Botox is a very developing area. Some initial studies have shown that Botox injected into the palm of the hand can help decrease ulcer formation. And we were very excited about these early studies. But more recent studies have shown varying effects. Some are positive, some are kind of equivocal. And the problem is that insurance companies have not seen this as a viable treatment yet because the great studies have not come out yet really proving efficacy. So I've had very difficult time having my patients get Botox covered by insurance. Let's talk about the surgical treatments. We've talked about the medical treatments, keeping hands warm, behavior modification, de-stressing, nifedipine. A lot of people use sildenafil as another treatment. That's a pretty standard treatment. Some people have had some success with Botox getting it covered. Many people have not. There are many clinical trials out there with some of the medications I showed. But let's say those have not worked well. Then we begin to talk about surgical treatments such as sympathectomy. And for this, we use the operating microscope. So here I take you into the operating room, and we actually use this microscope, which allows us to magnify the view 25 times, which is quite large. So 1 millimeter blood vessel shows up on the big screen as quite large for us to see and able to be operated on. Taking you through the anatomy of the blood flow to the hand, you can see this is called the axillary artery, the brachial artery. These are large blood vessels. Then we break off into the radial artery and the ulnar artery, and then we go into the hand. At this level in the fingers, the blood vessels are about 1 millimeter in diameter. At the level of the wrist, they should be about 1 to 2 millimeters in diameter, so still quite small. As we go into the hand, you can see that there's an arcade of blood vessels that forms. This is called an arch. So this is the ulnar artery, and this is the radial artery at the level of the wrist. This is where you take your pulse from. These are the big two named arteries that we really deal with, and both of these form into the hand. Those of you who are in the Bay Area know that I always talk about the analogy of two major highways, Route 280 and Route 101, who both go into San Francisco. So these are the main highways that go into the city, and as you get into San Francisco, you see the different roads and all the way out into the various neighborhoods. But the idea is that, like traffic, we want to ideally have two blood vessels that flow well into the hand. And here's another view of those two arches. So the radial artery forms this arch here, called the deep palmar arch, and then the ulnar artery forms this superficial arch. So there should be two complete circular arches that begin to feed into the hand. Let's say you come to our clinic and we begin to assess you because you feel that you have a lack of blood flow. So patients will come in and we'll do a physical examination. We'll try to see how well the fingers are perfused, looking at the flow to the tip of the fingers. We'll look for any kind of ulcerations. We will check the pulses in the palm and in the wrist and see if we kind of hold the blood flow to one if the other one still flows. So that's called an Allen's test. So we're getting a kind of a physical examination assessment of blood flow. But what is very useful are angiograms. And I'll show you lots of angiograms in the context of this talk. And I'll show you some normal angiograms first. There's angiograms, and there are CT angiograms, and then there are MR angiograms. But really, the gold standard still is a regular angiogram. And this is an example of an angiogram in a patient without scleroderma with excellent blood flow to the hand. And just in your mind, for the rest of the talk, keep this picture in the back of your mind, because this is what adequate, really great blood flow looks like. So what happens is when a patient gets an angiogram, dye is squirted down the axillary artery and brachial artery from the upper arm, like I showed you. And then this picture shows the dye going into the fingers. So here is the radial artery. Look how nice and thick that blood vessel is. Here's the ulnar artery. Here's one arch. Here is a second arch. And you can see these are called the common digital arteries because it goes into two fingers. And every finger should have two blood vessels, one on either side of the finger, that form this rich capillary bed at the tip of the finger. So this is really good blood flow. This is why in most patients, if they get a cut on the fingertips, it bleeds a lot because you want good blood flow to the tips of your fingers. So again, this is a normal angiogram. For the actual surgery for sympathectomy and a bypass, for scleroderma. This is what we do. We do 4 separate steps, and I'll take you through each one. One is, like I told you, the blood vessels seem to be innervated by sympathetic nerves. What this means, this is an ancient, response where if someone is, it's called the fight or flight response. If someone is being attacked by the woolly mammoth, eons ago, then all the blood should rush to the center of the body, the big muscles start working, and you run away from that woolly mammoth. You suck up all the blood flow from the fingertips and from the extremities and bring it into the core, and that's when things need to happen. However, that system is still present in us physiologically. So when we get stressed, when things aren't going well, then our fingertips tend to turn white because all the blood has clamped down. The blood vessels are clamped down because of these nerves, and the blood rushes to the core. So there are little nerves, as shown here, that actually go into each blood vessel. And so the first thing we do is we try to disconnect those little tiny nerves from the blood vessels so that we don't have as much of an aggressive response to suck the blood to the core anymore. So that's really what's called the sympathectomy. But specific in systemic sclerosis patients, and I'm going to highlight because this is probably the main point of my talk, is that specific to patients with systemic sclerosis is part 2. The blood vessels are encased in scar tissue here, and they get crimped down. And the analogy I use is like a garden hose in your yard that has twine wrapped tightly around the rubber garden hose. So the diameter of the garden hose is constricted, and water can't flow from it. Similarly, in the level of the wrist and in the hand, the little arteries get constricted by this scar tissue, and then it can't dilate and it can't distribute the blood flow as well. So the first step is to disconnect the nerves. The second step is to take the blood vessels and strip the outside material and scar tissue that's encasing the blood vessels. The third part of the surgery is if one of the major vessels, the ulnar artery or the radial artery, is clotted off, then if we can find a good proximal inflow and a good outflow, then we can do plumbing and we can replace that blood vessel with a new segment of vein that will act as an artery and increase blood flow. That's called a bypass. Similarly, like if you have a cardiac bypass and you bypass a blood vessel in the heart. Excuse me. And the fourth step is if there are ulcers to the tip of the finger while the patient is asleep and not feeling anything, we will clean off those ulcers aggressively so that it can be a fresh start to allow healing. So the 4 steps again, because this is the key part. One is the sympathectomy. The second is to remove the scar tissue around the blood vessels. The third, if possible, is to do a bypass graft. And the fourth is to clean up the ulcers. Okay, when do patients tend to benefit from the surgery? Well, right now, if patients have chronic ulceration, so their fingertip is always ulcerated and getting infected and all the medical treatments have been tried and nothing is working, that's an indication for the surgery. Or if the patient's always having severe pain, when you don't have blood flow to your hand, it hurts. It's kind of like having a heart attack. A heart attack is when the coronary arteries don't have enough blood flow to the muscle of the heart, and that actually hurts. So I call this problem hand ischemia, like a heart attack in the hand, because the blood vessels can't sustain the muscles and it hurts. And third, like I said, is if the current medications aren't working anymore and the patient's not healing the ulcers, then that's an indication for surgery. The question I pose in my practice, having treated over 100 patients with this condition, either surgically or non-surgically, is should we be operating earlier? And throughout the rest of the lecture, I'll try to tell you what I mean by that. Okay, so you remember that angiogram I showed you earlier on, the normal angiogram. I want you to contrast that to this one. This is one of the cases, and here's when I'll begin to show pictures that are fairly graphic. This is a nice woman, 40-year-old woman who had cold intolerance, had ulcers on the tip of her fingers, had a diagnosis of systemic sclerosis, and this is her angiogram. And you can see her radial artery is open, but her ulnar artery is completely clotted off. And into the hand, there's very little. The fingertips are right up here. There's very little blood flow going into the fingertips at all. So she's severely constricted in her flow. Here is the initial incision. We make an incision at the radial artery and ulnar artery. And this is just a palm incision with the skin flipped backwards. There's no skin missing. But here's the edge that'll go to here. The skin is just opened up and retracted backwards.
Hi,
and
James,
as we begin to...
James,
yes.
I want to let you know we're having trouble seeing the highlighter. So if you're using the pointer, okay.
Let me see. Do you see the highlighter now?
I'm not, but no, it's the...
Okay, how about this one? Do you see the highlighter here?
You know, I'm afraid not. I'm sorry. There might be a problem with the ReadyTalk.
Okay. So what I'll do is I'll just describe it a little bit better, okay? So if you see at the level of the wrist, there's two small incisions. That is to access the radial artery and the ulnar artery. And in the palm, it looks like a big hole, but it's not. It's the skin is incised and the skin is flipped backwards to expose the palm. And let's see, I'll show you a video here. And you can see here's the blood vessel. And you can see just under the microscope, that's why it's so involved. I'm dissecting it free. And you can see all that thick line tissue. That's the scleroderma tissue, thick scar tissue that I'm dissecting free. I'm dissecting right on the artery. And you can see I'm thinning up this vessel. And then you'll see blood begin to flow into the artery now. See, the artery should be nice and soft and spongy. You can see all this material that I've dissected free. And so we do that in a very careful way under the microscope. And then later on, as if you can see in a palm now, you'll see some blood vessels, and I'll blow it up there. You can see, so those blood vessels are now flowing with blood after they've been kind of released from the scar tissue. And this is the same patient 2 weeks after surgery. You can see on the hand on the left, that's the operated hand. You can see how that skin folds back nicely there. And the fingertips are red. They're getting blood flow. And contrast that to the unoperated side on the right. And then 6 months later, she's healed that big ulcer to the tip of her left index finger. This is another patient. This was a 55-year-old man with a 15-year history of scleroderma. He had a very painful ulcer for 6 months. And you can see, again, this is one of the major arteries, and we're dissecting all that thick scar tissue off the blood vessel so the blood vessel can flow better. And he healed the big ulcer to his middle finger. This is still on the operating table, obviously. The blood vessels have opened up. He healed his incisions and healed that ulcer at 8 weeks. This is an angiogram of a patient. You can see the angiogram on the left. Sorry, it's a little funky display of it there, but you can see how narrow the common digital arteries going into the hand are. And you can see on the right, this is after we've dissected them free. Those are nice blood vessels now. And here, I'll load this video of what we like to see. You can see the blood vessels now stripped of all their scar tissue, and they're kind of pumping away, delivering blood from the palm of the hand into the fingertips. Like I said, sometimes we're able to do a vascular bypass, and that's when we actually take out the segment of bad blood vessel that's not flowing at all. And we take a vein and then, splice in a new blood vessel. And here's an example of a patient through a larger incision, and you can see that's a new blood vessel that we've brought in. And so this is a really good thing because we're actually, not just stripping the scar tissue out of the blood vessel, but we're bringing in a whole new blood vessel that has a whole new spurt of blood going into it. Here's another example of a bypass. You can see this is a patient who had the ulnar artery bypassed. The little green pieces of material are just to highlight so you can see, by contrast, the blood vessel better. This is a patient who came to me quite late in her disease process, and as you can see, when I looked in there, all the common digital arteries were gone, and I couldn't find any vessels to bypass anymore or to even do a sympathectomy on. So After the surgery, the patients generally have keep their hand warm and not elevated. They just keep it in a normal position. We have a splint on for about a week. We take the splint off. Most patients feel relief of pain at about 2 weeks and healing of the ulcers by 2 to 3 months. The one caveat I want to make is that sometimes the hands can become stiffer after surgery. So patients who have nice, soft palmar skin then tend to do very well. But if patients have some stiffness and tightness to the palm skin, the surgery can make that a little bit stiffer. So that's an important thing to know preoperatively, and I always counsel my patients that they may end up having stiffer hands after this surgery. There have been other people who have done this surgery. These are my colleagues from Duke and North Carolina, Wake Forest and Duke, and so they operated on 22 patients there, showing, if you look at the bottom, significant increase in cutaneous perfusion in 16 of the 22 patients. This is another group, a small series from Pittsburgh, just 6 patients, but they showed significant improvements with healing of ulcers. This is borne out in small series around the country here. You can see the end is 6 patients, 7 patients, 6 patients, 11 patients. We looked at our own series at Stanford a few years ago. And again, I work with great rheumatologists, including Lori Chung here at Stanford. And we began to think of how good the outcome was. And you can see here, you don't really need to look at the details, but this was in 2013. At that time, we looked at the patients from 2003 to 2013. And at that time, we operated on 17 patients, so it's quite a larger series than some of the other ones reported with 26 hands. So as obviously many of the patients had done on both sides. The average year was 49 years old. All the patients had some, decreased blood flow to their hand. Many patients had pain, and there were quite a few digital ulcerations, and those were our main indications for the surgery. We performed a sympathectomy procedure, the dissecting of the blood vessels, in 26 hands, all of them, and then we did bypass in 3 of the hands. And you can see here that in the complications, 3 had a minor infection, 1 had an area of the wound opened up but healed, and 1 patient had a stitch that we needed to take out. But none of these needed surgical intervention. They tended to just be treated, in the clinic and do okay after that. Here are some of the results. Most notably, in the middle, you can see that patients healed their ulcer after this. And when we asked them, some patients wish they had the surgery a little bit earlier in the process. So in summary, from that part of the study, the sympathectomy was well tolerated. It was associated with pain improvement in most of the patients. There's a high rate of ulcer healing. And one thing that we talked about, began to see, is that in many cases we felt like we were coming to the surgery too late. When we go in and operate and we see that vessels are clotted off, that's not good. We wish we had seen the patients earlier before the blood vessels had clotted off. This is another patient that we did on, more recently. You can see on the left, the blood vessel is clotted off. You can see from my 2 instruments, that's the length of the clot. That means that area, that major blood vessel, the ulnar artery, has no flow at all. And so we have to replace it with a new blood vessel. Which brings us to the point of when is the optimal time for surgery. I think many people in the audience would want to know when is, can we predict the best time to surgery? Because there are risks to the surgery. I've talked about the possibility of stiffness to the hand or getting an infection after surgery. And just the pain and hassle of surgery is not a small undertaking. So if we operate too early, then, the risks of surgery will probably be higher than the benefits. If we operate too late on the other end of the spectrum, all the way over to the right, if I go in and the blood vessels are all clotted off, then there's not much I can do. I can try to do a bypass, but if I can't find a blood vessel at the end of the line to hook up to, then I can't do a bypass. And so we have to find that sweet spot in between. What I'll show you here is what I've been noticing over time, and really is are thinking, as I counsel patients, of thinking about getting a release a bit earlier in the process. And the main point is that I told you about the two main arteries, the radial artery, where you take your pulse from, and the ulnar artery, which is adjacent to it on the other side of the wrist. Those are the two main highways going into the hand. And what I've seen, looking at over 100 angiograms on different patients, is that the ulnar artery tends to clot off a lot more frequently. And so it's very much involved. And I'm going to show you a bunch of angiograms, almost like pattern recognition that I've seen over the last 10 years in my practice. So this is a classic one. If you look at the right side of this angiogram, the hand is upside down here. The right side, there's a blood vessel, but then it stops where it says U. That should be the ulnar artery, but it's absent there. So the ulnar artery is occluded. Here's another patient. The ulnar artery is occluded. Where it says U, the blood vessel just stops. So here's another one. The U shows where the ulnar artery is occluded. Here again, you can see with that good radial artery, that black line on the top of the hand there, that's good blood vessel. That's the angiogram showing the radial artery, but you can see where the red U is, the ulnar artery is occluded. So this is patient after patient I'm showing you. All these patients have their ulnar artery preferentially clotted off compared to the radial artery. And so this is a finding that's been seen in other practices. If you look at results from 2013 from my practice at Stanford, and these are angiograms, 25 patients, 45 hands, because many had bilateral angiograms, 39 of the angiograms shown here. And you can see the findings. Only 6% only 6.7% of patients was the radial artery occluded, but 64% of the ulnar arteries. That's amazing. That's more than half of the patients coming in to see me with scleroderma have their ulnar artery occluded. We have a classification scheme, and I'll tell you, most patients fall into type 2, where they have no ulnar artery at the wrist. So the ulnar artery is clotted off. So why is the ulnar artery more involved than the radial artery? And that is a very interesting finding that we're seeing. If you think about it, it's the same patient, so the genetics are the same. It's the same blood flow from the heart, so the physiology is the same. The immunology is the same. Again, this is like two different arteries right next to each other across the arm, across the wrist, and it's the same patient. And so the medication is the same. So the only thing different that we can think of between the radial artery and the ulnar artery is the anatomy, the local region, what tissue is surrounding this local area. And I'll show you here through a series of dissections in this patient here. If you look at the top, the radial artery is very superficial. It's right underneath the skin. So that's why we always take our pulse from the radial artery, because we can feel it. It's just underneath the skin. So here in this picture, I've just opened up the skin, and right underneath is the radial artery. However, the ulnar artery, which is at the bottom of the screen here, first of all, it's covered by a tendon. This is the FCU tendon. And then so it's not just the skin, but you don't even see the ulnar artery underneath the skin, because first it's covered by this tendon, and then it's got some tight fascial bands of the tendon. I'm dissecting underneath. I have to release this tendon, and underneath there's another layer of deep tissue. So if you think of a patient with systemic sclerosis or scleroderma, and the skin is tight, the tendon is tight, this layer is tight, and only after all that do I get down to the right level to dissect it free. And so here is the tendon that has to be moved out of the way. So I think it's the local environment there. The tendon is tight, and then in the patient with scleroderma, the skin gets tight, and everything gets tight, and over time it's like someone pushing pressure on it, and that causes the blood vessel to clot off. So what's going on now? So as of 2016, I've been doing this in my practice, this type of surgery in collaboration with the rheumatologist for about 13, 14 years now. And we've had 60 operations. All of them have sympathectomy. And you can see that the ulnar artery bypass is more common than the radial artery bypass. But many times I feel like I'm too late for the bypass. Again, if I can't find good flow in and good flow out, I can't do a bypass. So my new treatment goal is to really assess which patients had decreased flow in their ulnar artery early on. So the ulnar artery would still be working, but it's tightened by the tissue around it. And I think that would be an indication to just release that tissue and make it so that that external compression is not going on. And that's kind of the direction of where we're trying to assess patients. We do so a patient who comes in for a study, a new patient, we usually examine the patient, ensure that our rheumatologists have maximized medical treatment, and our rheumatologists now have known our practice and really referred to only to patients in their practice who they feel are possible candidates for surgery. Then we get, after examination and discussion with the patient, we get an angiogram because we need to see a roadmap of the hand. We need to see what blood vessels are open or closed already. And then we get an ultrasound of the hand where we're putting a probe on the outside, and we kind of try to see how fast that ulnar artery is flowing compared to the radial artery. And then we'll actually move the hand into different positions and see if the ulnar artery blood flow gets cut off with positioning. This is an example of a patient who had the surgery and the bypass. And you can see if you do a bypass, the blood flow is great. You can see here, the hand on the right is the one that we operated on. And you can see the pinkness to the fingers. The wounds are healing well. The ulcer has healed to the middle finger. And on the hand on the left, which is the patient's right hand, you can see how the fingers are still purple in this way. So just to summarize, I hope I've given you an update on the different possible surgical treatments for systemic sclerosis. Again, I'm not saying that every patient needs surgery. That's not the case at all. But that there are specific things we can do that may help a patient. For calcinosis, we take it out only if it's very painful or it's getting infected. If the patient has a little bit of calcinosis, and it's underneath the skin and is dormant and it's not causing any pain or problems, we advocate leaving it alone. If you have an MCP joint contracture that's extended, we really don't have a great treatment for that. So be very wary of signing up for surgery for that. If the PIP joints are really flexed down, we can get the finger in a better position, but we can only do that by fusing the bones and holding that position. Lastly, for ischemia and digital ulcerations, which is a major problem in patients with systemic sclerosis, in certain patients, sympathectomy and bypass can be very effective. And we're beginning to look towards doing this a bit earlier in the disease process so we don't go into surgery seeing clotted off blood vessels. Thank you very much. I've left my email here if you need to get in contact with me for any specific questions that I can't address today. And I'll talk to Amy about making those articles available to you for your own reading. Thank you. Amy, I'll turn it over to you.
Okay, great. Thank you so much, James. This has been super interesting information. We have about just a little over 20 minutes to go, and we are getting lots of questions in, so I can go ahead and provide you with some of these. We're getting lots of questions about, do you recommend fat injection into fingers and palm? Does it work temporarily or permanently?
Yeah, so that's a new treatment. There are different treatments of injecting some processed fat from the same patient, but there are no really good studies showing efficacy yet. We're beginning in the hand surgery world seeing some episodic reports of this. No one is really sure of the mechanism. I have not done this personally myself, and I probably don't plan to until I see some really compelling data out there.
Okay. Somebody's asking, why is the thumb usually spared in Raynaud's?
Oh, that's a really good question. So that means that for that specific patient or set of patients, the blood flow is better to the thumb. If you remember, I talked about the ulnar artery being clotted off more. That means the radial artery, which is closer to the thumb, is usually spared. And so I think in those patients, the thumb has better blood flow than the other fingers because the radial artery is still flowing, whereas the ulnar artery may not be flowing. And so that's why with each patient, we we look at their symptoms, and they may tell us, oh, it's the ring finger and small finger that's always turning purple, or it's the thumb. And then the angiogram, which is the roadmap, will match up very nicely to their symptoms. They'll say, oh my God, that's why my thumb stays pink with the other fingers. And so it's a great study to get to show them.
That makes sense. Is there anything that can be done to increase the flow of the ulnar artery? Is there physical therapy or something else that might be useful to try and keep the blood flow?
Yeah, so all the medical treatments and surgical treatments are geared towards that. So if you think of it as a plumbing issue, the medical treatments will prevent the blood vessels from hopefully clotting off on the inside or developing too much scar tissue on the outside. If that doesn't work, however, then it becomes a surgical problem. And if there's too much scar tissue around the blood vessels, the sympathectomy and the taking the tissue off will open up the blood vessels some more. It'll dilate up the blood vessels. Mm-hmm. However, if the ulnar artery flow is completely out, like I've shown you in the angiogram, the only possible thing we can do is to do a bypass graft, because that blood vessel, when we cut open that blood vessel, there's no hole in it anymore. It's completely clotted off. And so we actually have to take that part out. The problem is why we can't do a bypass on all the patients is because if the clotting gets distal enough, it goes into the palm, into the fingers, then there's no more flow going out all the way into the finger. The entire system beyond the ulnar artery is clotted off. And those are the cases that I feel frustrated because I can't hook it up to anything at the end. Mm-hmm. So a bypass is great if I can find somewhere to plug it into at the end. And that's what makes me think of why the ulnar artery clots off more and why, and then if we can kind of intervene earlier to prevent it clotting off. Ideally, in a perfect world, we want to get to that ulnar artery before it begins to clot off.
Yeah, you had mentioned that there were, how chronic does it have to be before you would intervene surgically, and then you had mentioned also too about drug failure. What's the typical length of time that you should try a drug and have it not work before?
Oh, yeah, that's a really hard question because there's so many new drugs coming on which can improve symptoms. So many patients who've had ulcers for a few years, the drugs may increase or dilate up the blood vessels enough to heal the ulcers. However, the underlying problem, the underlying anatomic problem still exists. So I worry that sometimes the drugs will kind of keep things at bay until the artery clots off. So in a perfect world, there will maybe be a lesser intervention earlier on, and then the medications can continue to help those results for the rest of the patient's career or lifetime, next 40, 50 years of medications coming. So my feeling, and again, this is from a surgical perspective, is the surgery can be done one time, and trying to find that perfect timing of that is what I want to spend the next 10 years doing.
Yeah. I have somebody asking, this is one of the questions that we got in advance of the webinar today, can mobility be restored in patients who have frozen hands? And I've had this question came up a few times.
Even so the hand is stiff already?
Yeah.
Unfortunately, we don't. And that's one of the very frustrating things in my practice. If a patient with scleroderma with any other condition has a really stiff hand and the skin is tight and the joints are tight, we surgeons really don't have a way of making things better. We may even make things worse. So in patients with scleroderma whose skin is whose joints are really tight, then when we do surgery, that can get worse. And I always talk to patients about that. But we don't have a surgery that takes away that global stiffness to the hand.
Okay. And then I've had a few questions come up about what can be done for calcifications that are really large.
Okay. So, one of the things I worry about is every time we cut into the hand, we're creating an ulcer, really. And so if a patient has marginal blood flow, barely getting by, and a big calcinosis, sometimes when we try to get the calcinosis out, then that wound will not heal well. So in a patient with a large calcinosis, it depends on where it is. If it's in the palm or in the base of the hand, it's less risky to take that out than at the fingertips. Mm-hmm. So it's a decision we have to make. And in some cases, if it's in the palm or in the base of the hand, I'll say, well, let's try to take it out, because these can be quite uncomfortable for patients. And so we can try to take them out through a small incision. If it's at the fingertips, and I know that the patient has decreased blood flow, we may combine the calcinosis excision with the sympathectomy so that we're making a cut on the tip of the finger, but we're also bringing in new blood flow at the same time. So that kind of mitigates the risk of having a non-healing wound after calcinosis.
Okay. I know we talked a little bit about fat injections, but somebody's asking about how do you feel about Botox for Raynaud's and to help the blood flow?
Yeah, I have many colleagues in the country who've used it. We've used a small amount. And again, the insurance companies are really a bear about this. They don't reimburse for that for the patients, and so I think that's worth trying if you can find the right clinical situation to try that. But again, I don't think it's going to reverse the entire process of an ulnar artery clotting off. So I would still advocate for having a surgery earlier on and then having medications and Botox that will help maintain those results later over time. Okay.
And then another question, do you do anything to the nerves during the surgery, or is it just the blood vessels?
So the little branches of the nerves that go into the blood vessels, for those segments, by stripping off all the stuff off the blood vessels, we take off the connection into the blood vessels from the nerves. Once in a while, we actually see a branch of the nerve that's going directly into the blood vessel, and we will remove that also. That's the sympathectomy part. But the whole concept is if you strip off everything around the blood vessel except the blood vessel itself, you're removing not only the scar tissue but the little nerves going into the vessel.
Let's see. We're trying to get a couple more questions in here. Let's see. Somebody's asking, why do nails get lost in this process of decreased blood flow?
So the tips of the fingers get hurt the most, unfortunately, because that's the end of the line. That's where the blood trickles down and there's not enough blood flow. So everything we see in scleroderma, the nail changes, the bone loss at the tip of the finger, it's called osteolysis, where the bone at the end just absorbs. The ulcers, that's because there's just not enough blood flow to the tips of the fingers, and all those changes. And as we, use our hands, we're always tapping with our fingertips, and that little bit of micro trauma in a patient with decreased blood flow results in those changes. When we talk about sympathectomy surgery, we're only talking about, so this is not a cure-all, but we're only talking about bringing maybe 10, 15, 20% more blood flow to the tips of the fingers. In many cases, that's enough to heal the ulcer. However, if the patient has already had nail changes or bone loss, even with a sympathectomy bringing in more blood flow, we're not able to reverse the changes that have happened already.
And I've had a couple of questions that are similar in nature. Are there any downsides to having the surgery, loss of grip strength, or being able to make a fist?
Absolutely. So yes, that's a key point, that I'm not advocating surgery for every patient with systemic sclerosis. There are the risks that we've shown you in our article, which include minor infections, stiffness to the hand. That's a major one. If your hand is stiff before surgery, it's going to be just as stiff or even a little bit stiffer after surgery. That's an important thing to know. The surgery, it's a day, and it's like a 4-hour operation in the operating room. It's a major surgery. The blood loss is very minimal because I have a tourniquet on when I do the surgery. It's also the incisions in the palm and the hand and the downtime from work. So the surgery, we really advocate the surgery only for patients who really are having, they're not getting any result from the medications. They're really suffering from pain in their hands, or they're having these recurrent ulcers that keep getting infected. Those are patients who would benefit from the current surgery. What I'm saying, and I'm hoping to get to in the next 5 to 10 years, is because I've seen so many patients with the ulnar artery clotted off. I'd love to see a patient fresh upon diagnosis of systemic sclerosis. As part of that workup, to get an ultrasound to see if that ulnar artery is tight in the tissue. And just go in and just release that ulnar artery, like I showed you in the last few pictures. Just do a smaller incision at the wrist. Just free up an ulnar artery. And then later on, that patient can still get a sympathectomy. And so the incision would just be in the wrist area. I think that could be a game changer early on and be more proactive rather than reactive.
Is this something that patients would talk with their physicians about to try and react to that early, or is that something that's
it's pretty new. We're coming out with a paper. I've reviewed 100 angiograms on patients with systemic sclerosis, showing about 60-some% chance of having the ulnar artery already clotted off when I see them. And then from that, we're trying to enroll new patients in getting this ultrasound to see how tight the ulnar artery is versus the radial artery. So you can imagine if I start advocating releasing the ulnar artery with a smaller operation, it's going to be 10, 15 years before we know if it made a difference, because we have to follow those patients and see if the ulnar arteries clot off or not. But the key point is, in my patient cohort of super nice, wonderful patients with scleroderma, more than half of patients that I see at the time I've seen them with the angiogram have the ulnar artery clotted off, and that's a really high number.
Right. I've had a few questions come up about the recurrence of ulcers and Raynaud's after the sympathectomy. Sorry.
Yeah.
So
that's a key. Yes. So that's a key point. That's a great question. So we can only do this surgery once because we're dissecting right on top of the blood vessel. And once we do the surgery once, we can't go back because more scar tissue has formed around it, so it gets riskier to do it again. And so I've been doing this for maybe 15, 16 years, and majority do fine. Some patients come back with more ulcers. We then treat them with medications and Botox, and then once in a while we have to go off and clean off the tip of that finger again. So we're beginning to see that. Less with the patients with bypasses because we've delivered a new blood vessel there. More with the patients who we couldn't do a bypass on. So we're beginning to see the whole spectrum. So the key point there is that we can only do the surgery once. Yes, in the patient's long lifetime afterwards, they will probably see more ulcers because the only thing we do in the surgery is we increase blood flow 10, 15, 20%. We don't change the hand completely. And so over time, that may continue to get worse.
Okay. Let's see. I'm trying to see if there's somebody is asking about the Cytori trial, if you're familiar with that, but I don't.
I don't have any detailed information of that trial.
Okay. I think we've answered most of the questions that I'm seeing here. So I guess we can wrap it up today for the day. I really want to thank you so much for your time. This was very informative, and I know a topic that's most important to patients, and so we really appreciate you taking the time to share your knowledge with our audience. A couple of things I want to just remind you of. Please be sure to register for our next webinar scheduled for December 15th. The topic will be skeletal myopathy and systemic sclerosis, led by Dr. Julie Paik. She's the Assistant Professor of Medicine at the Johns Hopkins Myositis Center. Again, thank you so much, James. We really appreciate you taking the time. And I want to remind everybody that all of our webinars are available on demand at srfcure.org, and we welcome your feedback. When you close the webinar window, please help us by completing a short survey. We're always interested in hearing what you want to hear about, so that would be really beneficial in helping us shape our sessions in the future. So please include any suggestions you might have. And then please remember that we depend on your support to continue our investment in the most promising research. For more information, visit us online at srfcure.org or call our offices at 1-800-441-CURE to support our program. Again, thank you so much, James, and thank you everybody for joining us today, and we look forward to having you join us in December.
My pleasure. Thank you, everybody.
Thank you.